I'm Dr. Anna Burke. I'm the director of the Alzheimer's and Memory Disorders Division at Barrow Neurological Institute in Phoenix, Arizona. I am a geriatric neuropsychiatrist, and I am also somebody who cared for two grandparents who suffered from dementia. So I feel very passionately about this particular topic. It is one of the reasons that I went into this field, having seen how the care that was provided to my own family was insufficient, and hoping to change the way that we provide care for our communities, for families who are struggling with this disease.
Hello, I'm Dr. Danielle Goldfarb. I'm a dual-trained neurologist and psychiatrist and memory specialist at the Banner Sun Health Research Institute in Sun City, Arizona. There's been such a change in our advances in our understanding of Alzheimer's disease on a neurobiologic level, and this is directly affecting our clinical care and diagnosis, and we'll talk about that today.
Early treatment for Alzheimer's disease really includes several different factors. We are looking at both pharmacological interventions. These can be symptomatic treatments, or now we have disease-modifying treatments available to us, as well as treatments of secondary symptoms. We do know that patients develop not just cognitive impairment as they're dealing with this illness, but oftentimes they will develop behavioral and psychological symptoms of dementia called BPSD. These can be anxiety, depression, agitation, even psychotic symptoms, so addressing those. And then non-pharmacological interventions, as well as supports and education of both the patient and the care partner, are a vital part of treatment of Alzheimer's disease, particularly in the early stages. So there are two different types of pharmacological treatment approaches that are available to us as dementia specialists right now. The first are symptomatic treatments. So symptomatic agents really aim to improve cognitive symptoms, or at least significantly slow the progression of those cognitive symptoms without necessarily altering the underlying course of the disease. With symptomatic treatments, what we are trying to do is we are trying to delay or improve some of the symptoms of the disease by targeting neurochemicals in the brain, neurotransmitters, and modifying their function. There are clinical trials that show us that these agents are able to improve certain cognitive measures like the Alzheimer's disease assessment scale, cognitive subscale, or ADAS-COG, in the range of about 1.5 to 3 points, with a corresponding change on mini mental status examination. Some of these agents have also been shown to potentially have some benefits on ameliorating neuropsychiatric symptoms, or reducing the emergence of new neuropsychiatric symptoms. But these treatments don't treat the underlying cause of the disease. Therefore, they're not really delaying the disease progression itself. And then we have disease-modifying treatments, or DMTs, which, unlike the symptomatic treatments, target the underlying pathogenic pathways of Alzheimer's disease to delay the onset or the progression of dementia. With DMTs, with these disease-modifying therapies, what we are doing is, instead of targeting neurotransmitters in the brain, we are really targeting what we believe are factors that lead to neuronal atrophy, to brain cell death, essentially. So the first FDA-approved disease-modifying therapy targets the amyloid pathway that is believed to affect the cascade that leads to neuronal degeneration. And by reducing that neuronal degeneration, it actually has the potential of slowing the damage that occurs to the brain and therefore slowing the disease progression. There are two groups of treatments that are currently available as far as symptomatic treatments. There were actually 4 cholinesterase inhibitors that were approved by the FDA. One of them has since been withdrawn due to side effects, but we currently have 3 cholinesterase inhibitors, donepezil, rivastigmine, and galantamine. We also have one NMDA receptor antagonist, which is MEMANTINE, which works a little bit differently than the other 3. In Alzheimer's disease, we know that patients have reduced cerebral content of choline acetyltransferase, which leads to a decrease in acetylcholine synthesis as well as impairment in cortical cholinergic function. So what these agents, these cholinesterase inhibitors do is they actually increase cholinergic transmission by inhibiting cholinesterase at the synaptic cleft. And therefore they provide a modest symptomatic benefit in patients with Alzheimer's disease. You can certainly divide the stages of Alzheimer's dementia in different ways. So mild dementia is generally where cognitive impairment starts to emerge. There are slight functional changes that start to emerge as well during these stages, typically in higher functions and instrumental activities of daily living, such as management of the finances, management of medications, maybe use of more complex appliances and electronics. When you look at the cognitive testing during these stages, on the MMSE, which is the mini mental status examination, patients will score typically between 21 and 25. On the Montreal Cognitive Assessment or MoCA test, they'll score an 18 to a 25. And they'll have a CDR of 1 during these stages. With moderate dementia, you will see that more functional impairments start to emerge. First of all, short-term memory becomes shorter. Functional impairments now start to encompass more activities that are kind of daily, simple activities. So you may see more difficulty with things like, using simple household appliances, using the coffee maker, the microwave. Driving certainly becomes impaired in these stages of illness. People, depending on where they are in that moderate stage, they may also start to have more difficulty with the steps in bathing or dressing, not getting them quite right, but still being able to do them. The MMSE during these stages is generally between 11 and 20. The MoCA test, generally the score is between 11 and 17, and the CDR is a 2. And then you have severe stages of illness, which is where patients start to have more difficulty in terms of cognitive function with even long-term memory. Certainly their executive function, their language abilities are more significantly impacted. And from a functional standpoint, they're really having more difficulty with more basic functions, and they may need more hands-on assistance with those tasks. In these stages, we do see that the MMSE is generally below 10, the MoCA is also below 10, and the CDR is a 3. As you diagnose a patient with mild to moderate dementia, it is important to take a multidisciplinary approach. In these stages, cholinesterase inhibitors are typically the first-line therapy. So something like donepezil, rivastigmine, galantamine. These cholinesterase inhibitors have shown modest benefits on measures of cognitive function and activities of daily living. They have shown to be able to slow declines on both these cognitive and functional measures when compared to placebo. It's also important to note that during these stages, you are also identifying potential issues, potential problems that may emerge. So looking at their cognitive testing, looking at what families may be telling you as far as some of the functional impairments that they're seeing, as well as what you're seeing on the cognitive test scores, whether the neuropsychological testing or the in-office screening test, you're going to start to identify a pattern. Let's say if they start to have executive dysfunction or some visuospatial deficits, well, you may need to have discussions regarding putting some additional supports in place. If executive dysfunction is emerging, the patient may start to have problems with things like managing finances, managing medications. So having a second set of eyes or having somebody take over those activities may be necessary. Certainly, if executive function and visuospatial abilities are affected, you may want to talk to your patient and their family about a driving assessment or even stopping driving. If they're living alone and struggling, you may want to have discussions about a higher level of support, a higher level of care. We know that cholinesterase inhibitors do not address the underlying cause of degeneration, that the disease continues to progress, the neuronal atrophy continues to progress. However, we do know that in the way that these medications help brain cells, if you will, communicate with each other a little bit better by adjusting neurotransmission, that they are able to delay decline in cognitive function. There are several reviews and meta-analyses showing that cognitive or cholinesterase inhibitors are able to delay cognitive decline on the ADAS-Cog. They are able to assist with or delay behavioral worsening and functional impairments over the course of 6 to 12-month periods. The benefits seem to be applicable to different stages of illness, both in the mild, moderate, and severe stages of Alzheimer's dementia. And when compared to placebo, patients on cholinesterase inhibitors generally show initial improvements in cognitive function over the first 3 months. Thereafter, the mean decline in cognitive function is also less rapid over the next 3 to 9 months. At 6 months, the cognitive improvement versus placebo on some of these tests has been shown to be 2.7 points over the mid-range of the ADAS-Cog. And most of these improvements in symptoms were in measures of attention, thinking, memory, praxis, language comprehension, as well as communication. So for the most part, cholinesterase inhibitors are pretty well tolerated. They do have some common side effects. These are generally gastrointestinal side effects. So patients may develop some nausea or diarrhea, in worst cases, vomiting. Dizziness is also a fairly common side effect. Less common side effects can include muscle cramping, almost Charlie horse type muscle cramping, rhinorrhea, or bradycardia. These medications may also exacerbate urinary incontinence, which is important to note because many patients over the course of their illness will develop some urinary incontinence. These side effects are really typically dose related, and they can be mitigated with a slow up titration to the desired maintenance dose. It's important to note also, we do have different formulations of cholinesterase inhibitors. So if a patient does develop some gastrointestinal symptoms with an oral agent like donepezil, you may want to consider a transdermal patch, like a rivastigmine patch, to see if they may be better able to tolerate that. MEMANTINE is a bit of a different agent. So MEMANTINE is an NMDA receptor antagonist, so N-methyl-D aspartate receptor antagonist. The mechanism of action of MEMANTINE is distinct from the other agents, the cholinergic agents, and it's proposed that it's potentially neuroprotective. There are several different neurotransmitters that are targeted by these symptomatic treatments. MEMANTINE tends to focus on another neurochemical called glutamate. Glutamate is the principal excitatory amino acid neurotransmitter in cortical and hippocampal neurons. One of the receptors activated by glutamate is the NMDA receptor, which is involved in learning and memory. And excessive stimulation of this NMDA receptor can actually lead to excitotoxicity. It's suggested that agents that block these pathological stimulations or overstimulations of NMDA receptors may protect against additional neuronal atrophy. MEMANTINE is one such agent. MEMANTINE does appear to have a positive effect, an improvement on cognition as well as global assessments of dementia. Relatively small improvement, but certainly present on clinical trials. The treatment effects of MEMANTINE seem to be of greatest benefit in individuals who are in the moderate to severe stages of Alzheimer's dementia. There have been really limited benefits shown in earlier stages of illness. In studies on parallel groups of patients with moderate to severe Alzheimer's dementia show a significant benefit on cognition, function, language, activities of daily living, as well as behaviors and global state, particularly when MEMANTINE is combined with cholinesterase inhibitors such as donepezil. So this is, again, generally well tolerated. In fact, most patients do tolerate MEMANTINE better than cholinesterase inhibitors. It can, however, cause some dizziness, headaches. In certain cases, patients can develop some confusion. And there is also a small group of patients that may develop agitation. Although I can tell you from clinical experience, we oftentimes see the opposite, more of a calming, relaxing effect when patients are started on this medication. There is very little, if any, evidence that patients with milder Alzheimer's disease or mild cognitive impairment would benefit from MEMANTINE. A systematic review reported the results of pooled data from 3 unpublished studies of MEMANTINE in mild to moderate Alzheimer's disease. Intention to treat analysis indicated a very small, but statistically significant beneficial effect of MEMANTINE at the 6-month mark on cognition, on the ADAS-Cog. But no effect on behaviors or activities of daily living. Another study analyzed data from 431 patients with mild Alzheimer's disease, so MMSE ranges from 20 to 23 from 3 trials, and found no substantial benefit with MEMANTINE in mild Alzheimer's disease. Also, no benefit was seen in patients assigned to MEMANTINE in the Department of Veterans Affairs Cooperative Study Program, which focused on early stage disease. It's important to note that there is nothing currently approved for treatment of mild cognitive impairment. Neither cholinesterase inhibitors nor MEMANTINE are approved for these stages of illness. Studies of cholinesterase inhibitors in patients with mild cognitive impairment have not shown convincing results. However, there is a trial of donepezil versus placebo that reported that the donepezil group had a lower rate of progression to dementia during the first year. However, at the endpoint of 3 years, the rate was not lower than that of the placebo group in the donepezil group. Other trials of donepezil showed statistically significant changes in Alzheimer's, in the ADAS-Cog, the Alzheimer's disease assessment scale cognitive subscale. However, the clinical relevance of those was questioned. And then rivastigmine and galantamine did not demonstrate a benefit for the progression to AD from the mild cognitive impairment stages. MEMANTINE similarly did not show benefit in the mild cognitive impairment stages in currently available clinical trials. So there is no strong evidence that these medications could be helpful. However, there may be a subset of patients who could potentially benefit. So recently, the first disease-modifying therapy was approved by the FDA. It's the first therapy really approved for treatment of Alzheimer's disease since 2003. And it was approved through a little bit of a different process, an accelerated approval pathway, which allowed biomarker evidence to be used as a surrogate that the drug was likely to be beneficial. However, the FDA did require that the pharmaceutical company that developed this drug show efficacy with additional studies, as well as safety with additional studies within the following 9 years after approval of this treatment. The way that this treatment works, the way that aducanumab, which is the name of the agent, works, is that unlike many of the therapies, the symptomatic treatments, it doesn't address neurotransmitter changes. Instead, it actually addresses the underlying pathology that leads to neuronal damage over time. The treatment is actually a recombinant monoclonal antibody that's directed against amyloid beta. And what it does is it, for lack of a better word, latches on to that amyloid and dissolves it, eliminates it from the brain. Reducing that amyloid buildup in the brain is believed to impact beneficially the cascade that leads to brain cell death over time. So we know that amyloid buildup in the brain can cause all kinds of damage, can draw in reactive cells, is involved in inflammation and in that whole cascade that leads to neuronal atrophy. The thinking is that if we can reduce amyloid beta plaques, we could potentially reduce some of that damage that occurs and slow the disease process over time. Aducanumab's approval did not come without controversy. The FDA approved aducanumab for the treatment of mild cognitive impairment or mild Alzheimer's dementia through an accelerated approval pathway, based on positive clinical trials of two pivotal phase 3 clinical trials. The results of the other trial were negative. And aducanumab was approved based on its effects on a surrogate endpoint of reducing amyloid beta plaques in the brain, not necessarily on an endpoint of improving cognition. So that caused a lot of controversy. There was also significant controversy as the FDA Scientific Advisory Panel had previously recommended against approval of aducanumab. And since the surrogate endpoint of reducing amyloid beta plaques was not yet established as predicting clinical benefit. Therefore, additional clinical trials were required, post-approval trials were required by the FDA to verify that clinical benefit. So in general, for disease-modifying therapy, we are trying to minimize the damage that's occurring to the brain. This therapy is generally most beneficial for people who are in the mild cognitive impairment and mild Alzheimer's dementia stages. This therapy also is appropriate only for patients who actually have documented amyloid pathology. We know that many patients, unfortunately, are misdiagnosed as suffering from Alzheimer's disease and may not necessarily have significant amyloid buildup in their brains. So if you are considering treatment with one of these disease-modifying therapies like aducanumab, a patient should undergo some kind of confirmatory study, whether that is an amyloid PET, positron emission tomography, or CSF studies of amyloid and tau. It's still unclear whether this therapy is going to be helpful in individuals with mixed dementias, like a mixed Alzheimer's and vascular dementia. We definitely do not want to be administering it to patients with Lewy body disease or with frontotemporal dementia. And even in certain populations, like Down syndrome individuals, there still needs to be additional testing done to determine whether the Alzheimer's dementia that occurs in Down syndrome should be treated with disease-modifying therapies such as this. You also want to avoid using this therapy in high-risk populations, people who are at high risk of hemorrhagic side effects. So those individuals who have more than 4 microhemorrhages on their MRI or any areas of superficial siderosis, prior macrohemorrhages, or any underlying brain lesions or vascular malformations, because that will increase the likelihood that they may develop a serious side effect such as ARIA-H or even a more serious bleed. Another controversy surrounding aducanumab was whether the benefits outweigh the potential risks. So unlike many of the symptomatic treatments that we have available now, these disease-modifying treatments have potentially more serious side effects. Now, in most cases, patients in clinical trials did tolerate this medication well. You could see some side effects like feeling more malaise for the next day after an infusion. But there was a large percentage, up to 40% of individuals in clinical trials that developed something called ARIA, or amyloid-related imaging abnormalities. And these could be either ARIA-E, which was basically vasogenic edema, or ARIA-H, which was basically hemorrhagic or typically microhemorrhages. You know that certain populations like ApoE4 carriers were more likely than non-carriers to develop these side effects. Many of these patients who developed these side effects didn't actually know that they had this ARIA. Only 24% of them were actually symptomatic. And if they did have symptoms, the typical symptoms were either headache, which occurred in about 13% of patients, confusion occurred in about 5% of patients, dizziness, which occurred in about 4% of patients, visual disturbances and nausea, each of which occurred at about 2% of patients. In most cases, in about 88% of cases after the treatment was stopped, these symptoms resolved, although it could take several months for these ARIA changes to resolve, to improve. Many of these patients were then restarted on the medication. And about 10% of these patients had more than one of these ARIA events emerge over the course of their treatment. So it is very important, if you are considering starting a patient on ADUCANUMAB, or as additional disease-modifying treatments may become available, that you monitor them very closely, not just with neurological examinations, because again, patients may not necessarily know that they have side effects, but also with neuroimaging. We do know that these neuroimaging changes can occur fairly early in the treatment. And in fact, most of these will occur within the first 8 doses of treatment. So during that particular period, close monitoring would be indicated. Since we do know that having the apolipoprotein epsilon 4 allele puts you at a greater risk of developing ARIA-H or ARIA-E, clinicians should discuss, first of all, should test for this allele before starting somebody on one of these therapies, but also should discuss this risk with patients. If you do decide to undergo ApoE, genotyping, genetic counseling should be offered to patients and to families prior to that testing.
With the enhanced technology and identification of biomarkers with Alzheimer's disease, there's this important window of time that we could potentially prevent Alzheimer's disease from progressing to become symptomatic, and that is where the research field is headed. At the same time, and that's where these disease-modifying treatments fit in, certainly. At the same time, what we've also identified and are more aware of now is that there's a major lack of brain health equity. And with all of these biomarkers and advances in our understanding, a lot of it, 95% of our research participants are Caucasian, non-Hispanic. And so we really need to do a better job of that to better understand this disease and these diseases. Now, in terms of shifting to our clinical care, I would say that as specialists in the memory field, we've always been delivering quite personalized medicine. We really learn about the individual, the family, who they are, what's important to them, and our treatment plans are infused with that. And that is what helps us. That understanding and that rapport is what helps the patient and the family buy into this and hear what we're saying and implement the changes, pharmacologic and lifestyle changes that we're recommending in partnership with them.
I think I would add to that we really understand that the type of care that we provide as specialists cannot be provided without really the help of our primary care colleagues. The treatment begins in the primary care setting. If you put all of us as cognitive disorders specialists together around the country, we're able to cover maybe 10% of the dementia population, which means that 90% of the care that is being provided in the primary care setting. So earlier assessments, supporting our primary care colleagues with appropriate tools to help them diagnose, help them manage patients in that setting is going to be key. It will really need to be one of the areas of focus of our advocacy in the future, making sure that we have these comprehensive types of supports available, not just in the specialty setting, but also in the general medical setting. I think as treatments begin to emerge, especially these newer disease modifying treatments, that earlier diagnosis is also, again, in the primary care setting, is also going to be even more important.